Hello, dear friends and colleagues. Today I'd like to talk about another very common topic, ankylosing spondylitis. You will get in your practical life as well as in exam. So, ankylosing spondylitis is a seronegative arthritis. So, why we are calling it seronegative, we have to know. Because rheumatoid factor is negative, anti-nuclear antibody is negative. For that reason, we are telling that ankylosing spondylitis is seronegative. So there are other arthropathy also seronegative. So what are those arthropathy? Another one, psoriatic arthropathy, enteropathic arthropathy, and reactive arthritis. Though, so these four entities, that is ankylosing spondylitis, psoriatic arthropathy, enteropathic arthropathy, and reactive arthritis, are seronegative arthritis. This four arthropathy follows similar criteria. So I'd like to talk about that criteria. What are those? First of all arthropathies cause rheumatoid factor negative, anti-nuclear antibody negative. Second, HLA-B27 positive. Third, axial involvement will be there. Fourth, there will be enthesitis and Achilles tendinitis. What is enthesitis? Enthesitis is inflammations of the ligament which is attached to the bone. Also, it will cause plantar fasciitis. So, these are the seronegative arthropathy and the criteria of seronegative arthropathy. Ankylosing spondylitis is the prototype arthropathy. So, when any patient, young age, usually 20 to 40 years of age, complain of pain in the back, which is increased after taking rest and relieved after walking or after doing activities. You have to think, in exam purpose, this patient may have ankylosing spondylitis. So ankylosing spondylitis, young aged male, usually all arthropathy cause the female predominant, but in case of ankylosing spondylitis is male predominant. Male is to female is 3:1. Okay, so male, young patient, pain in the back, both after taking rest and relieved, and get better after exercise or doing activities. You have to think about ankylosing spondylitis or other seronegative arthropathy. Now, just find out other things of DD to exclude whether it is ankylosing spondylitis or seronegative arthropathy. How we differentiate? Okay, if any person will have skin rash, extensor surface of the body, usually elbow, behind the ear, in the hairline, and the groin, around umbilicus, scaly rash, you have to think it is psoriatic arthropathy. Sometimes there will be no rash, but there is a features of seronegative arthropathy. Then you just examine the nail. If you find any onycholysis, sublingual hyperkeratosis, or change in the nail, pitting of the nail, um, then you have to think it is psoriatic arthropathy. Okay, patient is not having these symptoms. Patient came to you that patient is having chronic diarrhea, chronic bloody diarrhea. Maybe it is ulcerative colitis or Crohn's colitis. So Crohn's colitis, ulcerative colitis also can be associated with this type of arthropathy. It is called enteropathic arthritis. Another group of patient, young patient or any patient, come with the symptoms of urinary tract infection. Then there is joint pain, urinary tract infection, and some other features like change in the palm of hand, that is keratoderma blennorrhagica, or change in the external genitalia. This type of presentation you have to think about reactive arthropathy, reactive arthritis. So these 4 arthropathy you have to exclude. Symptoms we already mentioned, that patient will have low back pain. Pain will increase after taking rest and improve after activities. At the same time, patient will complain pain at night, and when he getting up, he will feel better. And also there will be joint pain and other symptoms of complications will be associated with this seronegative arthropathy, that means ankylosing spondylitis or other disease. So ankylosing spondylitis can be associated some other complication, extra articular manifestation also can be there. So I'd like to simplify this. Just remember the first letter of ankylosing spondylitis, A. So A for ankylosing spondylitis. Now you just start from above downward. In the eye, A for anterior uveitis. So patient will have anterior uveitis, and patient will complain of redness of eyes and grittiness of eye. Another A is for apical fibrosis, apical fibrosis of the lung. So patient will complain dry cough. These are the complications actually. So apical fibrosis can be present due to the complication of ankylosing spondylitis, another A. Apical fibrosis also will be associated with psoriatic arthropathy. A for aortic regurgitation. So also another A for aortic regurgitation. The symptoms of aortic regurgitation will find or sign. So you can get high volume pulse, you can get syncopal attack, you can get symptoms of left heart failure, pulmonary hypertension. This type of symptoms you can be associated with. Another symptoms, another A for AV block, atrioventricular block. So AV block, AV nodal block can cause complete heart block. Symptoms of complete heart block, that means bradycardia and syncopal attack. Another A for Achilles tendinitis. Achilles tendinitis, that means pain in the tendon of Achilles. Another A is for amyloidosis. So amyloidosis, if you follow my lecture, follow my video, I uploaded one amyloidosis. So you can get the symptoms of amyloidosis, including proteinuria, including diarrhea, including uh, macroglosia, carpal tunnel syndrome, what I mentioned in my amyloidosis video. So you can follow this, you can watch this. So patient will present with amyloidosis. So just remember A. And another A is for adalimumab. This is a biological agent, can be treated ankylosing by this adalimumab. So just remember A, so you can get all the symptoms, all the complications. Okay. Regarding apical fibrosis, I'd like to mention some other causes of apical fibrosis. Just remember, all connective tissue disorder cause basal fibrosis of the lung, except ankylosing spondylitis and psoriatic arthropathy, psoriasis. It will cause apical fibrosis. Another thing, just remember, all pneumoconiosis can cause apical fibrosis except asbestosis, which can cause basal fibrosis. Very important when I like to talk about respiratory disease, I'll mention. All drug can cause basal fibrosis. Just remember, you will get some question from this, and you will get some in case of station 2 or respiratory station in the spaces, you will get that the causes of basal fibrosis and causes of apical fibrosis. Okay. Now, this young patient will come to you when will already mention the symptoms and sign. Patient usually in exam will ask the what will be the initial presentation of this patient. Sometimes initial presentation will be pain in the buttock, alternatively pain in the buttock, which is radiated to the back. So you can get this pain, and when disease will be advanced, there will be sclerosis, there will be movement restricted, and you will get, when you exam, when you see the patient, you will see there is a question mark sign. That means loss of lumbar lordosis, thoracic kyphosis, and compensatory hyperextensions of the cervical region can cause question mark. Okay, so this patient will see, when we see that, and all the movement in the lumbar or thoracic region will be decreased or restricted, so patient cannot move separately. The whole body will move together. Patient cannot turn individually. There will be family history of ankylosing. Just remember this point. Okay. So in exam, we'll see the patient cannot move. Patient posture will remember. When we'll ask the patient, just stand by the wall. Patient can stand by the wall, but cannot touch the wall by his occipital region. So there will be gap. Remember, there will be gap around 5 centimeter. When we will ask the patient to take deep breath, there will be sclerosis of the joint, costovertebral joint. So there will be movement restricted of the chest, movement restriction of the chest. So when we will ask to take deep breath, the chest expansion will be reduced around 5 centimeter. Another, there is a Schubert test or modified Schubert test. When we will ask the patient bend forward, you just put one mark in the back. There is a dimple. Just mark that point, and 10 centimeter above another point, and ask the patient to bend. Usually normal person can bend more than 5 centimeter, but in case of uh, ankylosing spondylitis, it will reduce then 5 centimeter. So the dimple of venous 1 point, 10 centimeter above that point, and ask the patient to bend forward. Patient will unable to bend adequately. It will be less than 5 centimeter. So remember 5 centimeter. And modified sugar test, it will reduce 5 centimeter. Chest pressure reduce 5 centimeter, and occipital wall test will get 5 centimeter gap between the occiput and the wall. Okay. Now come to the investigation. We'll do normal investigation CBC. I'd like to talk about the specific investigation. If early involvement, then you just do rheumatoid factor test. It will be negative, and it will be negative. We'll do HLB27. It will be positive in case of 90%. Just remember, in case of 90% it will be positive, but in case of normal healthy person, 10% can be present positive HLB27. So question can come whether in normal person HLB27 can be positive or not. Your answer will be yes, 10% cases. Okay. Then we'll come to the investigation. Do X-ray and the sacroiliac joint. You will get some sign irregularity of the margin, the sclerosis of the margin, and after that you will get fusion. If you will do X-ray of the lumbosacral region, you will see the squaring of the vertebra. There will be syndesmophyte and ossifications of the anterior longitudinal ligament, which will give rise to some shape that is bamboo spine. You will see the bamboo spine in ankylosing spondylitis. Okay. But initially you will not find any change. In that case, the investigations of choice is MRI. MRI of the sacroiliac joint. The earliest possible diagnosis by doing that MRI of the sacroiliac joint. Okay. Now, other investigation you just do to exclude other things, or to see the complications of the ankylosing, like lung chest X-ray to see the lung fibrosis, urine RE to see the proteinuria, to see the whether there is amyloidosis or not, echocardiograph to see the whether there is any aortic regurgitation or not, ECG to see whether there is any heart block or not. So the other test will be the to exclude the complication. Okay. Now treatment. What will be the treatment? Initially, just encourage the patient that he need activities. Swimming is the best exercise. So swimming or physical activities, patient need to prevent the sclerosis and the stiffness or sclerosing of the joint. So exercise is the mainstay. Sometimes in an exam, patient usually in communication in the spaces, patient will ask that I need rest. For this patient, usually you will discuss with the patient, counsel the patient that rest will be harmful for you. So it is better to better to perform active life. Okay. So second thing is treatment of the pain, NSAID. Third, NSAIDs is not working, then you can go for biological agent like adalimumab, etanercept, infliximab you can use. Fourth thing, that physiotherapy is very essential component of the treatment. Fifth thing is sometimes DMRD will be effective only for those patient has a peripheral involvement, sulfasalazine. Okay. Sometimes a patient may need orthopedic intervention when there is sclerosis and there is some interruption or any other problem related to the movement. Then orthopedic surgery can be essential. And in case of peripheral pain, sometimes intravenous steroid can be effective. So these are the treatment. Complication already I mentioned, and other seronegative arthropathy, that the treatment of psoriatic arthropathy, treatment of psoriasis, and also treatment like ankylosing spondylitis. Enteropathic arthropathy, treatment of the ulcerative colitis or Crohn's disease. It will reduce the symptoms of arthritis. And treatment of reactive arthritis, treatment of UTI can give rise the reliefs of symptoms. So it is actually big topic, but it is very important in exam. So in exam there will be some question like this: is CLB27 positive or not? Rheumatoid factor present positive or not? It is seronegative arthritis or not? Patient will be younger, male predominant. Another male predominant also, you just remember, probably I told you that it is polyarthritis nodosa, and male predominant. So the male predominant, young age, axial, backache, usually at the end of the night, that is in the morning time, patient get up from sleep due to pain, and after getting up patient feel better. In the morning patient will get worse symptoms and activity. Patient will be feeling better. This is the prototype symptoms, and symptoms of complication also will be there. So just remember, A, patient may complain of antibiotics. Patient may present with apical fibrosis, with amyloidosis, or patient may present with aortic regurgitation. Mitral regurgitation also can be present, and heart block. So just remember these things. I think you can get question, and you can treat the patient in a practical life. That's all. I think I discussed about the main point, and just to go through this about ankylosing spondylitis, seronegative arthropathy, you will get a question from there. So thank you very much, my dear friend. Just subscribe my channel. I'll be again come to another topics with another topics, and just stay with me to get that all the topics which is related to the MRCP and other entrance examination. Thank you very much.